Hello and welcome to Preventing Diabetic Blindness, an innovative solution to achieving a 5-star goal. My name is Jason Crawford. I'll be your moderator for the session today. I serve as the Chief Executive Officer for Intelligent Retinal Imaging Systems, also known as IRIS. And we're going to be joined here by Cox Health System, a nice health system that has their leadership on the phone with us today. We're going to talk about their outcomes and some of their experiences in standing up and creating a diabetic retinal program in the primary care setting. I'll give us a brief overview on the mission that we're on to prevent diabetic blindness. And if we think about it, over 30 million patients with diabetes here in the United States, and we know that those patients are going to be at risk of losing their sight. Diabetic retinopathy, unfortunately, the leading cause of blindness in the United States. And when we look at the data, about 40 to 50% of those patients are having their annual eye exam. And there's a lot of barriers that are keeping, the current state for those patients to really go to the eye doctor and complete their exam. And we've known this for at least the last 15 years of a lot of education in that population, but yet still 40 to 50%, we haven't been able to really impact that as a healthcare system. And so those are leaving a lot of patients undetected annually if they have a retinal disorder that's progressing in the back of their eye. And it's causing diabetic retinopathy to continue to be the leading cause of blindness, even when we have 95% of the time we have the therapies and the treatments, and some retina specialists will even say 100% of the time, to keep these patients seeing, if we can only know that they're progressing through this track. And so it's been a renewed focus, an increased focus in the quality realm, with the diabetic retinal exam being a responsibility of the primary care physician. And so as we talk today to family physicians and providers and medical groups, we'd really like to hone in on, what are the leading factors to sustain and create a diabetic retinal program in the primary care setting, using the latest technology and the latest advancements. So a few goals that we have for today is that we'd like to give you the overview of these latest solutions, talk specifically, listen to this health system, Cox Health, talk about what it took for them to stand up their program, some of the tactics that they used in that process, what some of the outcomes have been now a year later, looking back at how their first year of the program has gone, and then talk a little bit about the workflows, the patient identification, some of the reimbursement questions that a lot of people have when they think about creating these programs in their health system. Today, we'll be joined by Dr. Mark Costley. Dr. Costley is the Medical Director of Regional Services. His role is to focus on the primary care setting across all of Cox Health System, and is responsible for the clinical programs that are deployed there, and he can share a little bit more about his background. And Brock Schammel as well, the Administrative Director of Regional Services. Brock's background is in administrative clinical support as the Director of Operations there, focused in the outpatient medical group setting. And so I'll turn it over to them, and let's kick it off, guys.
All right, next slide, please. First of all, I'd just like to say thank you. This is Brock Schammel from Cox Health. Would like to say thank you for the opportunity to just walk through our journey over the last year and what we have gone through as a major health system within Southwest Missouri, and just provide the ins and outs of what diabetic retinopathy and the disease of diabetes really is, how it's progressing within our area and within our health system. And so really want to start with who we are. And as an institution of 111 years of existence, we have seen obviously a major transformation of where we started to where we're at today, as we have 5 major hospitals, from tertiary to critical access. We also have a major orthopedic hospital and also an ED psych rehabilitation hospital within our infrastructure. We encompass over 80 clinics across Southwest Missouri in 25 different counties, stretching over 110 miles from one clinic to the other. And so we really do feel that we cover Southwest Missouri healthcare in our health system. We also have a Cox Health Plan to help cover insured lives and local businesses. We also provided a wide variety of healthcare services. When you look at what an integrated health system and tertiary health system does, we feel pretty confident that we're fulfilling that mission and vision. And so at this point, I'm actually going to turn it over to Dr. Costley just to kind of talk through how diabetes and specifically diabetic retinal exams came up on our radar. And so at this point, I'm going to actually ask that Jason forward our next slide.
Thanks, Brock. My name is Mark Costley. I'm the medical director, one of the medical directors here at Cox Health Systems. I took this job over about 3 years ago, and we had been working on diabetic eye exam for about the 3 years before I started, and then the 2 years after that. And in those 5 years, we really had never moved the gauge between 30 to 40% of our diabetic retinal exams getting done. So we were looking for innovative ways to do this. One of my administrators that I worked with ran into Jason at a meeting and a seminar, and Jason gave him his card and said that they were involved with diabetic retinal exams. And so when he came back, he gave me the card, and I called Jason, and we had about an hour-long discussion on the phone, and got me pretty excited because it made a lot of sense what they were doing. And that was around the 1st of January. We had a contract signed by the end of February, and June 20th, we went live. That was a pretty aggressive timeline, but we felt strongly that we needed to get it done. We've had some pretty good success with this. We basically, in the first year, did around 3,500 exams in the first 6 months. We had estimated around 24,000 patients with diabetes. One of the things this helped us with was really kind of nail that down. We're more right around 18,000. And so counting the 30% that we were getting done and the extra 3,000 to 4,000 patients that we did, by the end of the year, we had raised our percentages up between 60 to 70% just in 6 months with most of the patients that we were doing. It was interesting that the thing that this allows us is not just a camera and an image, it's a process. And that's the thing that has been most striking to us as we've done this, and it's the process that IRIS brings to us that's made this successful. Weekly data, we know which clinics are doing what, support, retraining for our folks. All of this has been so important to our success. Before we launched with IRIS, we had a residency here in our system, and they kind of wanting to be on cutting edge went out about 4 years ago and bought a camera and had a camera setting in the clinic and had it set up with the optometrists who were going to read this. It was all free. And even with that, with the camera, they were at 40% achievement. And as we looked at this, Jason was clear to point out that what they had was a camera but not a process. And that's what IRIS brought to the table for us, was process. So our integration went smoothly. We got things up and running. We were happy so far, and we'll discuss it more down the line what our success has been with this. But it's a great option for our patients who in that clinic, and we have rural clinics that are an hour away from the big hospital, and we have them able to do that right in the clinic where they're having this done. So it's been a great option for us. Next slide.
Okay, so this is Brock again. Just want to talk a little bit about how we did what we did, and going back to Dr. Costley's, I would say, revelation of exactly the problem we had, and it was just the lack of integration we had with a retinal exam, whether it be an optometrist or ophthalmologist or within our own residency program, and just knowing that we did not have a precise process to how we were going to do this. And so the first thing we did when evaluating where do we place these cameras is really try to dive into our patient population and split the numbers apart and really try to dive into the diabetic population and find those pods. And so we established 14 clinic locations to place 15 cameras across our integrated health system. And we did that solely based upon diabetic prevalence and trying to really land a camera in a place where we knew a lot of diabetics would be coming in, whether it be for primary care or for endocrinology care. The next thing we did is we knew we had to have strong integration within our electronic medical record. And as many healthcare providers or professionals can attest, that if it's not integrated within your EMR, you're probably not going to see a high success rate just for the fact that it's one extra step or one extra click or one other piece of paper that you need to track down. And so we work closely with our team here at Cox Health to embed this workflow within our Cerner day-to-day, and we're able to actually create a very smooth integration process in which our providers really have no visual of any outside workflow going on, and nor do our support staff who conduct these exams on a day-to-day basis. The other piece of that is that bidirectional piece of what we send out as far as the image comes back into the electronic medical record for a reporting purpose. So the provider who ordered the exam will see that result flow back into their inbox for review, which then obviously gives a care plan or a recommendation as to what they need to do with that patient next, which, don't ever provide a problem without a solution. And we feel confident that that's what we've set up from a workflow aspect. The other piece is just streamlined technical and clinical workflows, and knowing that this is always under evaluation. Whatever process you implement today is going to look different tomorrow, and just continuing to fine-tune the intricacies of that process, knowing that you have to make it better. And so what we've done today versus how we started, June 22nd of 2016 looks a little bit different. We continue to evaluate that workflow on a day-to-day basis and try to pull out any negatives or obstacles that our providers or staff go through. And overall, just the analytics piece and knowing that we know what providers are ordering the exam, we know what pathology is coming back, whether and by disease, so we know what we're seeing a high prevalence of. It allows for us to now start to evaluate what do we do with this patient population. Do we need extra resources? Do we need to put further diagnostic or therapeutic workflows in to help treat them and their disease? And so we're just excited that we now have a solution that allows for us to take the next step in progression. So,
Dr. Costley, this is Jason. Let me ask a question here. One of the things that decision makers are often thinking about when looking at their own medical group is this whole idea of an EHR interface and an EMR integration. And obviously, there's been a lot of history of companies that have tried that. It hasn't worked, and setting high expectations and then not delivering. Speak a little bit about, when we first started and you and I kind of looked at each other and said, gosh, we can't do this without an EMR integration. And then how that process went, working with, Cerner and getting that up to speed. Just share a little bit of insight there. I think that'd be helpful for folks.
Well, we set up a team to try to go forward, and as part of that team, we had, I think, 3 on your end and probably 3 to 4 on our end that were working on the MR integration. And at first, we kind of got the usual IT thing, we can have this done in 6 months, and we told them that was in March, and we told them, no, we're going live in June 20th, and they kind of gulped and said, okay, and then as we got further into it, they got pretty involved in it and pretty excited about it, and we were able to pretty much do that integration. Really, they had it done. We started in March, and they had it done by around first or mid-May for us to do that. It's perfect for our physicians because they order it in the office. It's an order results interface, and in the results section of Cerner the next day, the report comes up. The report's excellent. It gives the five different levels of retinopathy or normal, and then with each retinopathy level, it'll tell whether you have macular edema, macular holes, or what you see with that. And it also comes back with an ICD-10 diagnosis that helps us then when we code it with our RAF score. So it was a considerable undertaking, but our IT and SI3 group that is employed by Cerner dug in and really did a great job on getting that up and running for us.
Yeah. Yeah, that was a big, especially on I think we did it on about a 10-week schedule. And so that was a great project. Brock, when you think about, the solution and implementing this in primary care, talk a little bit about the technical and clinical workflows. And so from a staffing perspective, right, one of the things that we hear a lot of is, am I going to be able to fit this within my workflows? Speak a little bit about how long the test takes, and has it been a burden on the practice from a resource perspective? Share a little insight there.
Sure. Yeah. So let's start with how to staff around the exam. Knowing that the exam will probably take between 5 to 10 minutes, depending on the patient and what's going on with that patient that day. Really what we've determined is that, for anybody who's going to do probably more than 5 to 10 exams per day is probably going to need a staff member to really focus on that camera and provide that technical support in administering the exam and getting patients back into the daily workflow of the clinic, whether it be back to their office visit or to be escorted out of the clinic since their visit is done for that day. But really, what we have found is that we've been able to plant this within the actual exam process, meaning whether it's a vital before the visit or it's a referred service after the visit. And depending on volume, that's really what's going to drive where you plant that in the workflow. For a provider that is extremely busy, what we have found, it's better after the visit. For a provider who's a little bit slower than your atypical provider, you're probably going to want to use the dead time before that visit to administer that exam. And so Dr. Costley says this quite often, but the more we can pull the provider out of the workflow, the better we're going to be, because most providers simply just want to close that gap. They don't necessarily want to be a part of that process. They don't necessarily want to drive the process. They just want to make sure that the service gets completed. And so we've tried to really allow for our staff to drive when and where done in the exam or during the visit that day to ensure that that provider, again, does not have a negative impact in that additional workflow. So.
Yeah, no, those are some of the key questions I hear often. So that's good. Well, let's move into some of the results. And one of the good things about these programs is you have measurements and you have results. And so speak to some of those here, looking back on the last year.
This is Mark Costley again. We were in the first 6 months we went live between June 20th and December 31st. We were able to get around 3,500 exams done in that period of time. We raised our percentages from around 32 to around 60 to 70, depending on which plan that we looked at. We were pretty excited about that. We found basically in that period of time, probably 42 cases of site-saving pathology that we were able to save their site. We also found 3 to 5 cases of people that had asymptomatic strokes, and that was life savings. And the nice thing is that we get a call immediately the next morning, first thing, and the very first one of these cases that we had her at the ophthalmologist by 10 o'clock in the morning, and we had her then on in with the specialist for further anticoagulation and review later in the day. So it worked very well. Some interesting things that we found was it shows that we identified pathology in about 30% of the patients there. That also included glaucoma, hypertensive retinopathy, also some macular degeneration that we were able to pick up. So we pretty much found around 18 to 20% diabetic retinopathy. What we did after that with those 3,500 patients is we Brock and I as a system plugged in their hemoglobin A1s that came along with that and looked at that. And it was very interesting that we looked at hemoglobin A1s of 6.5 and below. We looked at hemoglobin A1s of 7 to 6.5, and we looked at hemoglobin A1s of 7.5 and above. And it was interesting that we found that in every group, the diabetic retinopathy was 18 to 20%. So we were able to go back to our physicians and kind of dispel the myth. If you've got diet-controlled diabetes and your hemoglobin is 6, that hemoglobin A1 is 6, that you don't need a diabetic eye exam. And we found several of those patients with hemoglobin A1s of 6 that had diabetic retinopathy, actually 18 to 20% of those people. So we felt that we really learned something from this. We convinced our physician that it works. And then the other thing that we talked to them about was we wanted them to look at this as a diabetic retinal exam, but also we wanted to look at it as another way of examining the control that the patient had with their diabetes. So we could actually look at the blood vessels in the patient, and actually in the clinic, you can actually walk in and look at the retinal exam and see what the blood vessels look like, and get a report back the next day, which is as valuable as a hemoglobin A1, or maybe at times even more valuable than that. So we were pretty excited with number one, the amount of sight that we probably saved, number two, the lives that we saved, and number three, some of the educational process that we were able to provide for our physicians, and how important this is as a test for them to be able to do in the office.
Mm-hmm. Mm-hmm. And Dr. Costley, your physicians there, you've had a lot of conversations with them. Some of them were early adopters, as we often have in populations. They jump right on it, get going. Some are a little more hesitant. They have questions. What would you say are some of the top questions that you received, in them adopting the technology and the process?
I think it was, number one, does it work? Number two, what's it going to cost the patient? Probably one gray area that we had were patients that said that they'd been to the optometrist or ophthalmologist, but we had no record of that. As we looked at our MA plans and our Medicare plans, we found that Medicare was covering 2 to 4 of these visits per year, and we told the physicians that to use their conscience when they were making this choice. But so far, we've not had any Medicare exams that have been denied, and I'm sure that there have been a few that we've doubled up on because they've had it done at the optometrist's office also. But interestingly, as we've worked with those folks, we've found that people tend to forget when it was done, how long ago, and it's probably better to go ahead and try to close the gap when they're there at the office at that time.
And what about a quick comment on the patient's reaction? How the patients, received this?
I think the patients that we've seen have been really grateful. We've had a couple of patients. We had a patient that had problems with her hearing, and she was one of those diabetics that was diet controlled with a hemoglobin A1 of 6.5 or below, and we found level 1 diabetic retinopathy with her. It was devastating to her because her sole sense was her sight, because her hearing was not very good, and she did a lot of reading and spent a lot of time with her family. And so she was very grateful whenever we found this, and that she knew that she can control this just by controlling her diabetes. So I think the patients have been very grateful for it. They really like the ability to have it done right in the office. At the same time, they're with their primary care physician getting something done.
That's great. Thanks for sharing that.
Yeah.
Okay, so this is Brock again. Just want to talk through a little bit on the risk side, and knowing that healthcare is a risk-based model where essentially health systems are responsible for ensuring that patients are receiving the right services to protect them from disease progression, or at least to limit the disease progression to a rate that can be at least controlled as the best that it can be. And so obviously you want to get credit for that. And as the risk adjustment factor has made its way into the evaluation and essentially setting of those per member per month capitation models, what we have found is through the retinal program, we've been able to capture new disease that we were not getting credit for before we had this retinal program going within our primary care clinics, and know that primary care is typically the housing company for that risk adjustment factor. Primary care physicians often are responsible for ensuring that disease is captured on claim data on an annual basis. And so by having the two together, it's allowed for us to, within our first year, over 651 RAF diagnosis that we now can get credit for, and hopefully get paid for the risk that these patients possess. And so obviously, you know, we've alluded to the heightened scoring on the Medicare Advantage plans, going from 30% at one point to now up to 60 to 70%. You know, that's publicized data. That's data that patients are shopping essentially to try and determine, okay, where do I want to get my health care? And so that data being publicized out there really sharpens us to try to provide the best resource we can. And I'll, you know, kind of go back to within the primary care setting. If patients walk out of the office without a service, you know, the statistics show that there are about 40% compliance rate associated with that versus a 70 to 80% compliance rate for the service when it's performed in the office when they're having their actual exam with the provider. So we have just continued to try to close these gaps, and in the end, you just want to get credit for what you're doing and what you're providing to. So it's been a great success for us.
Well, I know that you know, there's other questions folks have, and as they think about taking this approach of a physician practice-based, really diagnostic test, and the thought process about working that into their workflows and making it successful within the primary care clinic, you know, there's deep impact on how does that impact my physicians, how does that impact specialists, you know, the eye care providers that may be employed within my system, they may be community physicians that we interact with a lot, you know, how, you know, and then thinking about from the patient perspective. And so I know that we often get a lot of questions along those lines, but as you guys think about your program, you know, what are some key takeaways that maybe you'd share with others, you know, based on your experience? If you were to say, you know, here are a few things to think about, kind of keys to success, or any advice you'd have for folks considering a program like yours.
Yeah, this is Mark Costley again. I think if you look at it, if you stratify it in different levels, for example, you start with the patient. The patient we knew that there were 70% of our patients who were probably not getting something done. At least we weren't getting it documented and know where it's at. So we've raised that up. It's convenient for the patient. The patient is in the office. They get it done at the same time. They walk down, they get their lab done, they go around the corner, they get their iris test done. It takes 2 to 15 minutes depending on the test, but most of the tests, 80% of the tests take between 2 to 5 minutes to do, and it's slick, it's easy, and they have a result back the next day. Our physicians at another level are excited about this because they can close care gaps, but more importantly, they can take care of their patient right in their office and know what's going on. It's an ability to look at the blood vessels inside their patients' bodies and know what they look like. At the system level, we've been excited about it because it's helped us to close care gaps. It's raised our RAF scores. We're really happy with it. And kind of interestingly, at the level of our referral with our ophthalmologist, at first they were a little reticent and a little bit hesitant because they thought we were going to be trying to steal some patients. But what's happened as we've developed a relationship with them is they've realized that we've sent them more appropriate patients. And I actually got an email the other day. It was like, as we've come to the year's end and we've gotten most of our diabetic done, our numbers have dropped down just a little bit because we're a year into it and we've done 70% of our diabetics. And so they actually had kind of noticed at the ophthalmology office that their numbers had dropped down a little bit, and he wanted to make sure that everything was happening appropriately because they noticed it. They saw what we were sending them, and they seemed to be appropriate, and they were happy with that. So I think at all different levels, we've been very successful with this. I think the last takeaway point is, I alluded to this earlier, I talked about it, is this is a process. It's not a camera and an ophthalmologist. It's a process. It's where we put everything together and package it to make it successful with the patient, with the physician, with the system. And part of that is because of the program that Iris has set up and their ability to work with us, with their people, with the data, with what we're getting weekly with them. So overall, our takeaway is it's been successful for us.
Yeah, and I would add, just being on this side of watching the last year and watching you operate, is that it takes ongoing good communications and perseverance, right, to take a new process, get it up and running. And so when I think back on your example of communication with ophthalmologists, at first those communications weren't great. And then they began to see the results. And then we had to kind of clarify some things with data, which is always very powerful. This is the data. This is how the program is going. And then over time but consistently throughout the way, I think that a lot of folks underestimate the fact that you have to have good physician leadership and communications, and that you are disrupting a current workflow and ultimately though focusing on better outcomes. And so I think both you, Dr. Costley, from a physician communication perspective, and then Brock, the amount of time that you've spent working with the staff and communicating with the staff, listening to their concerns. I think those are some outcomes I would add that I've observed. Well, as I wrap up, as we look back, really the purpose of IRIS is to set these programs and design systems, use innovation, use technology, use workflows to design systems to help you achieve your outcomes, right? Providers deliver care. Companies like IRIS need to deliver the tools that allow you to do that successfully. So we're on a mission to end preventable blindness. We believe at our core that there's no reason in the United States of America a patient should go and become blind from diabetic retinopathy. When we have the tools and the specialists can treat them, all we have to do is catch them at the right time. And prevention is a lot more valuable than reaction. And so we want to improve access, increase quality outcomes, and decrease cost of care. And we'll continue to do that as we grow. As we look at, or as you consider, kind of your programs, I think that I'm excited about the next phase of development. I often talk, because I'm an old Army guy, about crawl, walk, run. And you start with the need to get to HEDIS compliance and the fact that you have a quality care gap. That's the crawl phase. Just getting the program installed, getting it stabilized, getting it where it needs to be. I'm excited about the walk phase, which is this next level of insights that we get from the data, as Dr. Costley talked about, the data on the population correlating with the A1C score. How do we make that consumable at the point of care where we actually start thinking about how that impacts those, and really getting even better at driving the care gap and making sure everyone has their diabetic retinal exam and managing that referral to the right specialist. And then the run phase, as we begin to deploy new technologies, whether it be a automatic machine learning read that immediately at the point of care gives the patient and the primary care provider instant feedback on, are we seeing, does the computer believe that we have sight-threatening disease or not, right there at the point of care, so we can take action and continue to. And then as we go and we think about, can we correlate this back to cardiovascular risk, to the risk of other end organ damage like renal failure or Alzheimer's. So our job is to continue to give you the tools, the processes, and take these programs to the next level. This has been a great session. Dr. Costley and Brock, and for all the work you've done at Cox Health, we greatly appreciate that. If you'd like to have more information, please reach out to us, and we'll make ourselves available to help you think about designing a program that would fit your needs at your health system. Thanks for taking the time to listen to the information we provided today, and we look forward to speaking with you soon.